introduce Dr. Pless?
Yep, absolutely. So good morning, everyone. It is a pleasure for me to introduce Dr. Misha Pless this morning, who's our guest speaker for today, and he'll be talking to us about visual fields and cellular disorders. So I just want to give you a brief summary of his career. So he got his MD at Emory, then went on to Harvard to do residency in neurology, then a fellowship in neuro-ophthalmology in Harvard, then went on to UPMC for his first faculty position, and then continued to grow from an assistant professor to an associate professor to a full professor where he went to Switzerland to continue his practice. And then after Switzerland, we were lucky enough to recruit him here at Mayo, Florida. So he is now a consultant with us here at Mayo, Florida. And below you can see a couple of his selected honors and awards. And then some selected publications right here. And then on the next slide, we have his H index, which I know the leadership team here at Mayo, Florida tracks all the citations and the H index to see the impact that the consultants have been having in the literature. And as you can see, Dr. Pless has had a big impact in the literature. So welcome, Dr. Pless. It's a pleasure to have you here today.
Thank you very much.
Misha, thank you.
Thanks a lot. Is the voice coming through okay?
Yes, it's perfect.
Great. So let me then share my, my screen. Can everyone see my screen?
Perfect, Misha, perfect.
Great. Okay, well, I dedicate this lecture to the residents and people in training that are present here. And the title of the lecture is Diagnostic Challenges in Lesions of the Sella. And here are a series of clinical pearls. They're very short clinical pearls that exemplify what we do in neuro-ophthalmology and exemplify and illustrate the role of visual fields in the diagnosis. I will not be talking about optical coherence tomography specifically. I left that out. It's a very, very important tool that we use nowadays. Of course, the clinical examination is very important. And I'm going to focus primarily on visual fields because visual fields are our friends in neuro-ophthalmology. And I want to hopefully impart upon the people in training the importance of being able to use visual fields in the work that, that is done in the area of the sella. So visual field testing is a little bit like looking at an impressionist painting. When you look at it from real up close, you don't really see much. You see a lot of detail, but you don't get the full picture. You have to step back a little bit, and then you see what that image that I just showed you is a part of. It's a part of a painting by Kokoschka of Cathedral. This is the Florence Duomo. And if you step back, then you realize what this is, which is really the case with Impressionist paintings. So visual fields are very much dependent on how you look at them. And if you are a comprehensivist, and if you're in the era of the paper chart, hopefully not too many of us are doing that anymore, but people outside the United States might be still looking at paper chart. You'll see the visual fields are represented in pages, and there's a page for the right eye and there's a page for the left eye, and you really miss the neurogenic patterns. If you're a retina doctor and you have this contraption on your head, you look at visual fields as some sort of, well, you know, I'll get the information by looking at the retina, period. If you're a glaucoma doctor, you're looking at the very fine details of each visual field separately to see progression from one eye to from one visit to the next. And you're looking at the details of this huge amount of information that comes out with every printout. If you are a neuro-ophthalmologist, however, you sit back, you put the right eye on the right side, the left eye on the left side, and remember that's the way that you're supposed to look at visual fields. You step back and you look for neuroanatomical localization. How are the visual field defects respecting the vertical meridian and the equator? Very, very important point. So, a quick primer. These are visual fields, automated visual fields. There are many different types of examining the human visual field, but this is one of them. The right eye is on the right side, the left eye is on the left side. And here, just a quick primer. I'm going to use my pointer. I hope you can see it. The gray scale that we're used to seeing is just a gray representation of where the visual field defects are. The darker the area, the less the patient sees. What we as neuro-ophthalmologists actually do, of course, we look at the performance. If the patient is sleepy, the performance is poor. But we look at the data, at the raw data, which I'm demonstrating here, the deviation from normal. And we see that the black dots, the darker the dots, the less the patient sees. So I'm going to be showing you a series of visual field defects through this presentation, short clinical vignettes that exemplify a significant challenge in visual field testing. And this person here has the vertical meridian, that's the right eye. The visual field defect is to the temporal side of the vertical meridian, and the left eye also. Now, if you look at this patient's left eye separately from the right eye, you might miss this pattern. And this is a patient, a 67-year-old woman with a history of I can't really see my own slides because I have this bar that I'm going to bring to the bottom. There we go. A 67-year-old woman with subtle symptoms of loss of vision and headache was diagnosed with severe migraines over 2 years. And now you see the visual field testing here is a classic bitemporal depression. We don't see a bitemporal cut. You don't see a blackout of the bitemporal, in a bitemporal pattern. You actually see a depression. You are not seeing these visual field defects any longer. We hope that the patients are diagnosed prior to getting to this particular stage. This is a stage that you see in end-stage chiasmal compression. And this is what bitemporal visual field defects are portrayed like in textbooks. This is what you learn, but this is not what you see in practice. What you see in practice is this, going back to this patient's visual field, is a much more subtle visual field defect, and therefore patients are oftentimes missed. This is a patient that was diagnosed with migraines that, sure enough, has a non-secreting pituitary adenoma. These pituitary adenomas, unfortunately, because they're non-secreting, are late to diagnosis. Here you can see that the sella is abnormal. There's this large tumor that expands north and south, so to speak, and the chiasm is pressed against the gyra recti and compressed and giving these small visual field defects. Now, let me tell you, each case will have a pearl. The pearls to remember here are that some very large, slow-growing tumors cause subtle, if any, visual field defect. So if your tumor secretes a hormone that allows for early detection, then you're lucky. And of course, we all know that you do not make the diagnosis of migraines in adult or older patients de novo. The next vignette is a young woman who has trouble getting pregnant, has headache and loss of color vision in one eye. That's really the only symptom. Has a history of infertility and, believe it or not, galactorrhea prior to conception. Had transient visual blurring prior to conception and worsening headaches as the pregnancy progressed. Had seen 3 ophthalmologists, 1 neurologist, and received a list of diagnoses that are listed here that include somatization disorder, which is unfortunately the case, and delayed diagnosis. You look at the visual field testing, and here I'll argue that this is a perfectly pristine visual field test. You see the blind spots, you look at the deviation from normal, and there's absolutely nothing. But you do an imaging study because you're worried about this patient. And she wondered why she had started to lactate before she got pregnant, had a history of infertility, had transient visual blurring, and sure enough, came to an astute neuro-ophthalmologist that finally said, we need to look at this case because of the color vision deficit. Now, the pearl to remember here, and here I know that I'm preaching to the choir because this is part and parcel of what we do, but we have to listen to a patient and get an endocrine review of systems when there are visual symptoms. Always. Is there gynecomastia? Is there galactorrhea? Is there hair loss or hair growth in unusual areas? Is there erectile dysfunction? These are the difficult questions that need to be asked, and we in neuro-ophthalmology always ask them. The next vignette has to do with a professional golf player, and anyone that plays golf knows that they need to see the ball. And when the ball went far away, the patient could not see the ball any longer and carried with him a history of low tension glaucoma. Low tension glaucoma and its cousin disease to normal pressure hydrocephalus is a diagnosis of exclusion, and you need to take this diagnosis with a grain of salt. He was told that his symptoms were due to the low tension glaucoma, and here you see the examination. Visual acuity is actually normal. Color vision is normal. Tension, so that's intraocular pressure, is normal. And there is a relative afferent pupillary defect in the left eye. Very, very important to check the pupils in darkness. The cup to disc ratio, 0.4 on the right side, 0.8 on the left side. And here's a fundus photo showing the right optic nerve has a normal cup and the left optic nerve is highly excavated. So this patient gets a visual field test, and here the visual field test shows the subtle, very, very subtle visual field depression on the temporal side of the right eye and on the temporal side of the left eye. These are very subtle visual field defects, but both eyes have them on the temporal side. So this is a very subtle bitemporal depression. The patient gets a scan, and sure enough, there's a very large pituitary adenoma that is compressing the chiasm upwards. So the pearl to remember here, for those of you that see patients that might carry this diagnosis, is that normal tension, or so-called low tension glaucoma, very much like its cousin disease, if you will, normal pressure hydrocephalus, is a diagnosis of exclusion. And you need to analyze the visual field defect very carefully and image the patient if in question. Of course, always looking for a neurogenic pattern of visual field defect. The next vignette has to do with this older carpenter that presented with a sudden onset visual field defect. Had a CT scan that was read as negative and received a diagnosis of mini stroke, and for the visual field defects was sent to a neuro-ophthalmologist. And here is the visual field test. This visual field shows a right-sided, so it's how the patient is seeing it, right-sided homonymous superior quadrantenopia. It's a beautiful quadrantenopia that's displayed here. How can this be consistent with a negative cranial CT? Well, this CT was read as negative, but as you can see, there's something in the cella, something that perhaps today would have been interpreted as empty cella. But sure enough, the patient actually had a cyst in later investigations. This cyst, well, you can see here the patient's supine in the scanner, and it shows a very nice fluid level. Now, you have to be careful with normal CTs, especially when you are looking at visual field defects that are not explained. I do not accept the diagnosis of mini stroke or lacoon unless I've seen something a little bit more substantial. So routine cranial CT is not an ideal way to evaluate the cell and chiasm unless there's a contraindication to MRI. The optic tract, which is where the lesion is here, cannot be ignored. So this is a chiasm that is relatively intact, but it is the optic tract which is being impacted upon. And therefore, there is a homonymous visual field defect associated with this expanding cyst. The next case is a man that is seen in the eye doctor's office with non-specific symptoms, has a visual field defect that is said to be eyelid artifact. Now, we see that on a regular basis. Patients that are sent to us with eyelid artifact, could this be neurological? Now, you look at this visual field defect. This is the right eye. This is the left eye. The left eye has a superior defect that is far beyond where one would expect an eyelid artifact. In the right eye, you could say, okay, this is eyelid artifact, someone that is sleepy or has low-hanging eyelids or redundant tissue that falls over the normal eyelid, but the left eye, definitely not. And you step back, like I said previously, and you look at this visual field defect and you say, well, it's on the right side and it's a homonymous visual field defect. So this is a neurogenic pattern for sure. And sure enough, the patient gets imaged for this so-called eyelid artifact and a cystic calcified craniopharyngioma is diagnosed. Now, craniopharyngiomas are very, very tricky because they interact with the chiasm in unusual ways and sometimes parasitize vessels from the chiasm itself, causing microinfarctions that don't look like the normal chiasm compression. So in neuro-ophthalmology, we're always looking for relationships to the vertical meridian. We're almost obsessed with it, and we're very leery of eyelid artifacts. The next case, moving right along, is an older woman with visual field defects from cataracts. And that's another red flag. Slit lamp examination shows mild cataracts in both eyes. However, a relative afferent pupillary defect in the right eye is documented but not addressed. Now, in retrospect, when we looked at the fundi, we definitely saw that the optic nerve had atrophy. I mean, you can see that this optic nerve has a different color than the left optic nerve. The right optic nerve has temporal atrophy. And therefore, in retrospect, neuro-ophthalmologists look at things and say, well, that was present. 2 years later, the patient gets a set of visual field tests. And here you can see a different pattern, a pattern of constriction in almost all directions. You can see the right eye has like a ring scotoma, more or less, or half ring. In the left eye, the same. And the central sensitivity is relatively spared. Now, this is a patient that had a giant supraclinoid aneurysm compressing the chiasm. And here the issue is, again, where do these lesions impact the optic apparatus? Very important to note that every person's anatomy is different than the next person. And lesions of the cella and the suprasellar cistern impact the chiasm in different ways. If the chiasm is prefixed, that means the crossing is prior to the pituitary gland. Any growth in that region might actually cause an optic tract type of visual field defect. However, if the chiasm is post-fixed, that means what sits on top of the pituitary gland is actually the optic nerves and not the chiasm. You actually get either junctional, the so-called junctional visual field defects, or you get optic nerve type of visual field defect. So the optic neuropathy, and here is a representation of the relationships of the cella contents with the actual cross. It can be highly variable. So if you see a patient with an APD, a relative afferent pupillary defect, Marcus Gunn pupil, talk to your neuro-ophthalmology colleagues, and we love these collaborations. The next two cases are nearly identical tumors, but with two very different stories. And this is something we see in neuro-ophthalmology on a daily basis, two different visual deficit results from identical tumors. And the first one is a basketball player falls on the court, hits his head, and has an MRI that shows an abnormality. A visual field test is absolutely pristine, as normal. You see central sensitivity is normal. The blind spots are normal. You get a scan and you see this. You see a very large mass that I'm just showing you one picture here is a visual pathway glioma. So this is a juvenile pilocytic astrocytoma diagnosed incidentally in a patient that then later on went on to receive the diagnosis of neurofibromatosis type 1. You see this gigantic chiasm, well, that's tumorous in a patient that is actually totally visually asymptomatic. Take the next patient who's 14 years old, has known neurofibromatosis type 1, Lish nodules. You see these little excrescences, nodules on the iris that are hyperpigmented, and has known bilateral optic atrophy. Now, these are Goldman visual field tests, Goldman. They don't just test the central 30 degrees, but they test the entirety of the visual field. Again, the right side on the right, the left side on the left. And you can see here a huge cut inferiorly in the left eye, inferiorly in the right eye, also superiorly in the right eye. These are complex visual field defects in a patient with the exact same tumor. And you can see here an axial and a sagittal, a non-contrast enhancing tumor of the optic apparatus, a visual pathway juvenile pilocytic astrocytoma. So here are the pros to remember are that intrinsic chiasmal tumors such as visual pathway glioma may present with enormous variety in the range of visual loss. You can't extrapolate the size of the tumor and the severity. And just to mention, we follow these tumors for years. Sometimes, even if there is visual loss, we, of course, don't recommend surgery any longer. The next two cases, two dramatic cases, demonstrate two very different visual outcomes. Two patients that experienced hemorrhagic pituitary adenoma scenarios. Patient 1 on the left side, patient 2 on the left side. The patient 1 and patient 2 had very different visual outcomes, and you're just not going to be able to guess what the visual outcomes are with these two patients. Now, you can see patient 2 first, the one with this very large pituitary tumor, has a visual acuity of 2200 in the right eye and 2080 in the left eye. Now, this is a patient that is awaiting pituitary resection, has a history of atrial fibrillation, is anticoagulated, and while awaiting pituitary tumor surgery, has a bleed inside the tumor leading to these acuities. Now, you wouldn't guess from the size of this ginormous tumor that God knows where the chiasm is, somewhere between the tumor and the third ventricle, probably the lateral ventricles, that this visual acuity is real, but it was real. These are all cases from the clinical practice. Now, look at the other patient. This patient is in the operating room undergoing a total hip replacement, experiences loss of blood flow, hemodynamic instability, receives transfusions, has a rocky operative course because of blood loss, and wakes up in the recovery room blind. Now, this is a patient who underwent pituitary apoplexy intraoperatively and has a moderately sized tumor, much smaller than the previous case that you saw. Also blood products inside this pituitary tumor, but here it is the expansion speed that actually is important. The pearl here to remember is that in this particular case, it was the speed of expansion that caused the blindness. Now, all of these cases had very good outcomes, had recovery of vision very, very nicely post-operatively. The next case is a woman that is followed over a 5-year period for cataracts. And sure enough, the examination shows 2+ cataracts in the right eye, 1+ cataract in the left eye. And you see here the visual field testing. Now, this is probably one of the more important vignettes that I want to show the residents, where in the right eye, there is a central visual field defect, and in the left eye, there is a temporal visual field defect. Take a look at this. The majority of these little black dots in the left eye respect the vertical meridian quite accurately. This is a case that is always very important as a teaching point. Why? Because there are tumors, like here, this tuberculum cell meningioma, that cause these heterogeneous visual field defects. The first pearl to remember is that behind cataracts, I've mentioned this before, and other media-related pathology, there sometimes lurks neurogenic pathology. So you have to be alert. But the more important point here is that a monocular temporal visual field defect, which respects the vertical meridian, is suspicious of chiasmal pathology unless proven otherwise. Now, the classical teaching is that bitemporal visual field defects imply chiasmal compression. But all you need is one eye with a visual field defect of this type that respects the vertical meridian. Regardless of what's happening in the other eye, the patient could have been monocular, could have lost the right eye. If you see this, image the patient. The next vignette, moving right along, we're getting to the end, is an ornithologist, very much like our friend the golfer, relies on vision very, very much, and says there's something wrong with my eyes. Receives a diagnosis of glaucoma. Here is again our friend glaucoma sneaking in and causing confusion. Positive family history of glaucoma, so the diagnosis fits very nicely. Is followed for 1 year. Visual acuities are very nice, normal. Tension, intraocular pressures are high normal or slightly elevated, 21 millimeters of mercury being the highest level of normal. And the cup to disc ratio is 0.5, so no big cup to disc ratio enlargement. You see here the visual field defects. In the right eye, the visual field defect respects the vertical meridian very, very accurately. In the left eye, it spills over. So here again, demonstrating the principle that what you need is one eye with a visual field defect that respects the vertical meridian to allow you to scan. And sure enough, you scan this patient and you see this heterogeneous, multi-loculated tumor involving the chiasm. The chiasm is splayed upwards. There's a cystic component, there's a calcified component. And again, craniopharyngiomas are complicated tumors that affect the chiasm in unusual and unexpected ways. One of the last cases I want to show you is a young woman that presents with subacute bilateral visual loss. You examine the visual fields and you find this. Now, this is a little variation on the theme. I've been talking about the respect of the vertical meridian. And what you see here are bitemporal visual field defects that do not respect the vertical meridian. What's going on here? Is this something else? Is this eyelid artifact? Is this, well, what is this? Yes, indeed, the majority of the depression is on the temporal side on both eyes. So you say, let's image this patient. You image the patient and initially the answer is the scan is normal. But then as a doubting Thomas, as all neuroophthalmologists need to be, you look back on the MRI and you see that the chiasm is actually white. The chiasm is white, you can see here. It doesn't have a white matter signal. It actually has gray matter signal. And this is chiasmal neuritis or optic chiasmitis. It's a manifestation of demyelinating disease. So the pearls to remember here are that intrinsic chiasmatic lesions do not respect the vertical meridian, and demyelination or otherwise, let's say, sarcoid or inflammatory lesions of the chiasm are often missed by incorrect MRI sequences. and by someone that's not suspecting the chiasm as a localization. A very, very similar case is an older woman with bilateral loss of vision. A cranial CT and an MRI show a small left occipital hemorrhage. A visual field test, well, were you expecting a homonymous hemianopia, as would be the case with a posterior quadrant hemorrhage from, let's say, a cavernoma? Well, you actually don't get that. You get central loss in the right eye and ring depression in the left eye, and you scratch your head and you say, what is going on here? You look at the scan a little more critically, and actually what you see is a hemorrhagic chiasmal cavernoma. This patient has two cavernomas, one in the occipital, well, parieto-occipital region, and one in the chiasm. And the one in the chiasm was ignored at first because it's very small and it's present in only one sequence. So don't always assume that a parieto-occipital lesion will lead to a visual field defect. Sometimes they don't. So intrinsic hemorrhagic or inflammatory chiasmal lesions may present in non-classic ways, mimicking other types of lesions, including anything you can think of. The last case, as dessert, exemplifies the role in which we as neuro-ophthalmologists sometimes found ourselves. These are neurosurgical referrals for preoperative diagnosis prior to pituitary adenoma. I feel that our role as neuro-ophthalmologists is to clarify the difference between ocular pathology and optic pathway pathology. So this is a patient that has a pituitary adenoma, has visual symptoms, and is sent to us for preoperative evaluation prior to endoscopic resection. Has a history of anisometropia. What is that? Is when one eye has a different refraction than the other. Let's say one eye is hyperopic, the other one is myopic. So here the right eye is myopic. You can see it's a tilted, slightly dysmorphic optic nerve with peripapillary atrophy, and the left optic nerve is highly cupped. Visual acuity in the right is 20/20, in the left eye is 20/25, and the pressures are high in both eyes. The left optic nerve is deeply cupped, and sure enough, you look at the visual field test, and you see that the patient does have a classic visual field defect that we see in glaucoma. Here, the majority of the depression that you can see here in the grayscale is inferonasal. That's classic for glaucoma. The right eye doesn't have a defect yet. This is a case of true, and unrelated, so that the patient does have a pituitary, a large pituitary. We don't know if it's tumorous or just hyperplastic, but it's not reaching the chiasm. The patient has glaucoma and has pituitary, let's say a microadenoma. So that our role as neuro-ophthalmologists is to clarify these things so that the patient has clear expectations and the neurosurgical colleagues are informed as to exactly what is going on with the patient. So in order to understand these, we need to really know the neuroanatomy. We need to be able to understand what the neurosurgical colleagues are doing, and of course, know the neuroanatomy, which is our bread and butter. So after saying that, I want to say that I truly enjoy the work that we do as neuro-ophthalmologists with our neurosurgical colleagues. It's a real pleasure to be here to work with this incredible team and to be part of this team, and look forward to the next chapter of my career. I'm very, very excited. Thank you so much.
So great, Dr. Pless. It's a beautiful, great pleasure to have you and to see the picture with your family. Just closes the presentation so beautifully. Amazing pearls. You can see everybody was stuck and listening to all your pearls. I know that I just saw a comment right there by Dr. Mead. Dr. Mead, and I have a question by Dr. Perez Vega, but we'll start with Dr. Mead. Go ahead.
Good morning. I just wanted to say thank you, Dr. Pless. I learned a lot.
Beautiful.
Thank you very much.
You. Carlos, wonderful. Carlos, I see that your hand is up. Go for it.
Yes, sir. Thank you. Good
morning.
morning.
Follow with JP.
Thank you, Dr. Pless. Thank you for such a educational and illustrative presentation. As Paola said, we learned a lot today. I would like to ask you about predictive factors for visual recovery in patients with pituitary lesions. So do you think the visual tests could be used as predictors for visual recovery, or would you usually use other resources? I know there's been some studies with OCT regarding how much vision these patients can recover, but I would like to hear your opinion on that.
So Carlos, thanks for the comment. I specifically left optical coherence tomography, which is a critical tool that we use for the workup and assessment of patients with pituitary or with sella region lesions. And to answer your question, the OCT is a much better predictor than any of the other techniques that we use. In other words, when there is retinal nerve fiber layer loss, and I'll go one step further to say when there is ganglion cell layer loss, which is another step in our understanding of how optical coherence tomography works, then the prognosis is worse. So in other words, if the compression has been present for a long time and there is erosion of the optic apparatus, and if there is optic nerve atrophy and retinal nerve fiber layer loss, the prognosis is worse. That's not to say that we sometimes see really dramatic recoveries. That's certainly the case. The visual acuity sometimes recovers very nicely, but other aspects of visual system don't, like color vision, like contrast sensitivity, and the visual field. So visual acuity is one of those rough measures of visual function. So to go back to your question, OCT, which I actually specifically left out because it's another huge topic, and which we use on a regular basis. I mean, we use that every day with all the patients that you sent us, is the best predictor.
So maybe what we can do, Dr. Pless, if it's okay with you, maybe we'll prepare a lecture, have you come and join us in a few months for the second part of this series, which is the OCT, which is, as you said, it's another topic that we can have in the future. And giving you clarity in the way, I'm sure that our audience will love to hear about that. Is that okay if we get you already, sort of engaged in a future lecture on this topic?
Absolutely. As many lectures as you want. I have
beautiful. I have two. Beautiful. No, we plan with Andres and our team. I have two comments, and then I'm going to go to JP as the last question. There's a comment right here by Dr. Fox. Wonderful talk. Thank you for bringing clarity to these often confusing lesions. Then Susan Sampson, great to have you on the pituitary team, Dr. Pless. Looking forward to collaborations. And then, of course, Gabriel Vargas. What is the reason why some patients recover their vision compared to others, even some who are nearly blind? We'll answer that question, then we'll end up with JP. That was Dr. Vargas from Bucaramanga.
The reason has to do with, it's a very, very complex question. There are some tumors that actually, as I said, with regards to craniopharyngioma, that parasitize vessels from the chiasm. The dome of the tumor or the tumor itself actually becomes entangled in the chiasm vasculature, so that if you attempt to remove the tumor too aggressively, you actually devascularize the chiasm. And what you see is sometimes even if tumors that are not so large, and a post-surgical neuroimaging study looks beautiful, and the patient might be blind because in extracting the tumor, you actually infarct the chiasm. We see those cases occasionally. Thankfully, they're the minority, but it's difficult to tell. Now, we know that some meningiomas that are present chronically, and craniopharyngiomas specifically that have been present for years, they can parasitize vessels, and they cause infarction by aggressive tumor resection. But thankfully, those are the minority of cases. And of course, chronicity of compression leads to a slightly worse prognosis.
Thank you, Gabriel, for the question, and thank you, Misha, for the answer. So recently we had a few of those cases that we presented in our Friday conference. I know you've been involved in, and we reviewed them with Susan. They parasite, especially those craniopharyngiomas, completely stuck right on the belly of the chiasm, and it's impossible to separate them. And we work for hours, and what we feel is that we just, as you say, we're just going to traumatize the optic chiasm. There's no great solution, and some other ones that just come out beautifully. So let's see, one last question by Dr. Almeida. JP, please.
Hi, Dr. Pless. First of all, congratulations on your presentation. And to me, it's always a pleasure to put a name to the notes that I see, because I love your notes in clinic. Like, it's almost like you are operating with us through the notes, and it's always fantastic. So thank you very much for your help. I have a twofold question. The first one is complementary to Carlos about, he asked about OCT. I would ask you your impression, opinion about GTI and fiber tracting of the optic tracts and for visual recovery prediction. And the second question is on the topic of apoplexy. And here it's more your impression about cranial nerve, like especially oculomotor nerve recovery, because we have been looking at that, and we have the impression that the recovery with surgery versus conservative management, the results are quite similar in terms of third nerve and fourth, sixth nerve palsy. So I just wanted to have your perspective on that. I know it's a bit out of the optic nerve topic, but would be glad to hear you.
So regarding your the first part of your question, DTI is a technique that we will be using more and more. We were just at the neuro-ophthalmology meeting, and there were a couple of lectures on DTI as an emerging technique, both for demyelinating diseases, but clearly will be, because the optic chiasm is so heavily myelinated, and actually the structure lends itself to tensor imaging. I think that it's an additional technique that will allow us to look at the myelinated fibers as they cross the chiasm in greater detail. I mean, the imaging stuff with 7 Tesla is beautiful, and I think we're going to be in a position to use that as an additional clinical technique. Now, the second part of the question is very, very difficult. It's a huge question. Why the oculomotor nerve sometimes does well in patients that, let's say, have very large prolactinomas, and you treat them medically with medical therapy as opposed to surgical therapy. The third nerve and the chiasm are two very different birds of prey. Not only is the chiasm in a different milieu, it's in the subarachnoid space, and it's surrounded by CSF. The third nerve in the region is in the cavernous sinus, and it has more hard structures next to it, the dura and the bone, so the lateral wall of the sella. So that's different considerations. The third nerve gets a harder impact, and actually the third nerve is extremely resilient. I mean, you see meningiomas in the cavernous sinus that are very large that cause a sixth nerve palsy, but not a third nerve palsy. How can you explain that? I mean, it's the tumor is enveloping the entire structure, and yet the third nerve is very resilient. In my experience, once the third nerve is involved in the cavernous sinus, it is very hard to predict what's going to happen with medical therapy and with surgical therapy. I have to say that size does not matter. Tumor type does not matter. Softer tumors do better than harder tumors. But as a rule, if there is an acute third from a pituitary apoplexy, that in my experience, they tend to do better with surgical intervention.
Beautiful.
Thank you very much.
Thank you, Misha. Thank you, JP, for all the questions. And sorry that we went a little bit over time, but you see so many people that stay behind to listen to these concluding remarks and your pearls. We're very appreciative. We're looking forward to the next part of your lecture. We're ready. Put it on the lounging pad right there, and then we'll suggest some times and see if they work with you, Misha. We're so excited to have you here. Everybody's excited to have you here, and I love the description of JP saying we feel like you're operating with us, when we read your notes, and it's beautiful. Same thing with Dr. Sampson as far as our pituitary, surgery case. We have an amazing, in our neurology, we have an amazing team, and we thank everybody. So we come to the end of this beautiful Monday. I know the world is going through a lot right now, and I hope that these positive messages and these interactions at least bring a little bit of happiness to a world that is going through extraordinary, difficult times. So thanks, everybody. Have a wonderful, wonderful week. Adios.
Bogotá.